Metabolic acid-base balances. Welcome. First, we'll talk about metabolic acidosis. Metabolic acidosis, when it first happens, is clinically called acute metabolic acidosis. Acute metabolic acidosis is present when the PCO2 reading is within normal limits, 35 to 45 torr, and the pH and bicarb readings are both lower than expected for this normal PCO2 level. An example on an ABG would be that the pH would be 7.25 and the bicarb would be 17 milliequivalents per liter, both of which are lower than normal range. The PCO2 is 40, normal, and with these readings, you can confirm acute metabolic acidosis. Common causes of metabolic acidosis are lactic acidosis, a fixed acid problem, and ketoacidosis, also a fixed acid problem. Aspirin overdose also is a fixed acid problem. However, renal failure and uncontrolled diarrhea are a loss of hydrogen ions. All of these can contribute to metabolic acidosis. But how do we tell what caused the problem? We're going to look at the anion gap. The anion gap is a value also available on the ABG. We use the anion gap to determine if a patient's metabolic acidosis is caused by either an accumulation of fixed acids, such as lactic acidosis, ketoacidosis, or an overdose of aspirin, or if a person's metabolic acidosis is caused by excessive loss of bicarb, as in diarrhea or kidney failure. The normal range for an anion gap is 9 to 14 milliequivalents per liter. An anion gap greater than 14 milliequivalents per liter represents metabolic acidosis. An elevated anion gap is most commonly caused by an accumulation of fixed acids, lactic acids, ketoacids, or salicylic intoxication. However, hydrogen ions generated by fixed acids chemically react with and are buffered by plasma bicarb. Some of the causes of this are bicarb concentration diminishes or anion gap increases. Clinically, when a patient presents with both metabolic acidosis and an increased anion gap, the respiratory therapist must investigate further to determine the source of the fixed acids and to appropriately treat the patient. For example, metabolic acidosis caused by lactic acids justifies the need for oxygen therapy to help reverse the accumulation of the lactic acids. However, metabolic acidosis caused by ketone acids or ketoacidosis, often seen in diabetics, justifies the need for insulin to reverse the accumulation of acids. Interestingly enough, metabolic acidosis, which is caused by excessive loss of bicarb, does not cause the anion gap to increase, as seen in renal disease and severe diarrhea. summarize, when the metabolic acidosis is accompanied by an increased anion gap, the most likely cause of the acidosis is fixed acids, lactic acids, keto acids, or salicylic intoxication. When the metabolic acidosis is accompanied by a normal anion gap, the most likely cause of the acidosis is excessive loss of bicarb, such as in renal disease or severe diarrhea. Let's talk about metabolic acidosis with respiratory compensation, or partially compensated metabolic acidosis. Under normal conditions, immediate compensatory response to metabolic acidosis is an increased respiratory rate. This causes the PaCO2 to fall. As the PaCO2 diminishes, hydrogen ion concentration also decreases, helping to offset the metabolic acidosis. Alveolar hyperventilation. Alveolar hyperventilation causes the P big A, or alveolar CO2, and plasma CO2, carbonic acid, and bicarb to all decrease. This increases the bicarb to carbonic acid ratio, normally 20:1. However, if this ratio increases, this will increase the blood pH. In partially compensated metabolic acidosis, an ABG example is pH of 7.30, lower than the normal range, a PaCO2 of 25, lower than the normal range from an increased respiratory rate, and bicarb of 12 milliequivalents per liter, lower than the normal range. The metabolic acidosis with partial respiratory compensation can be confirmed. The pH has not returned to the normal range. The CO2 has already lowered, which starts to happen within a minute or two, and the bicarb is low. Metabolic acidosis with complete respiratory compensation is present when the PaCO2 decreases to the point that the acidic pH moves back into the normal range. Fully compensated metabolic acidosis on ABG would have a pH of 7.35, of CO2 of 20 torr, a bicarb of 12. Let's break that down. The pH at 7.35 is in normal range, but just barely. It's on the acid side. The PaCO2 is low in response to an increased respiratory rate, which happened because the bicarb had fallen to 12, well below the normal range of 22 milliequivalents to 28. Metabolic alkalosis. Let's talk about acute metabolic alkalosis first. Acute metabolic alkalosis is metabolic alkalosis that has just happened. The respiratory system has not had time to compensate. For example, when the reported PaCO2 is normal, 40, at a time when the pH is 7.50, raised, greater than 7.45, and the bicarb is 31, greater than a normal of 28, metabolic alkalosis is confirmed. Common causes of metabolic alkalosis include hypokalemia and hypokalemic hypochloremia. Those are big words. Just not enough potassium in the body and not enough chloride. Either one can cause metabolic alkalosis. Gastric suctioning, common in ICU patients, or vomiting, as well as administration of corticosteroids, excessive administration of sodium bicarbonate, diuretic therapy, Lasix, and hypovolemia, often seen with a low blood pressure, are common causes of a low potassium and low chloride, two of the most common reasons for metabolic alkalosis. Let's talk about when the lungs start to compensate for a metabolic alkalosis. Under normal conditions, there is almost an immediate compensatory response by the lungs to the metabolic alkalosis. It happens with a decreased respiratory rate. This causes the P(a)CO2 to rise, and as the P(a)CO2 increases, hydrogen ion concentration increases. This offsets the metabolic alkalosis. The mechanism is shown in the illustration here. As you can see, alveolar hypoventilation or a low respiratory rate causes the P(a)CO2 and the plasma CO2, the carbonic acid, and the bicarb to increase. In turn, this decreases the ratio of bicarb to carbonic acid, and in turn decreases the blood pH. Let's look at an ABG example of partially compensated metabolic alkalosis, or metabolic alkalosis with respiratory compensation. In this case, the pH is elevated at 7.450, greater than 745. The PCO2 is 60 torr, again elevated well above a normal range of 35 to 45 torr. The bicarb is elevated at 46 milliequivalents per liter, well above the normal range of 22 to 28 milliequivalents per liter. Metabolic alkalosis, in this case with partial respiratory compensation, is confirmed to be present. Let's talk about what metabolic alkalosis with complete respiratory compensation looks like. A fully compensated metabolic alkalosis is present when the PaCO2 increases enough to move the alkalotic pH back into the normal range. For example, the pH would be 7.45, just within the normal range. The PaCO2 would be greater than 45. The bicarb would be greater than 28 milliequivalents per liter. Base excess or deficit. By knowing the base excess or deficit, the non-respiratory acid-base imbalances can be quantified. It's important to be able to do that with both the BE or base excess and the anion gap. We talked about anion gap. We're going to talk about base excess or deficit. For example, a base excess will help you in identifying metabolic alkalosis that can be treated by correcting the underlying electrolyte problem. Often hypokalemia or hypochloremia. This can be corrected by administering ammonium chloride. Let's talk briefly about combined acid-base problems, and we'll start with a combined acidosis. Combined metabolic and respiratory acidosis is also called a mixed acidosis. An ABG for mixed acidosis would look like an acidotic pH, a pH that is very low, lower than 7.35, a PCO2 that is high, greater than 45, and a bicarb that's low, lower than 22. For example, a pH of 7.10, acidotic, a CO2 of 70 torr, acidotic, a bicarb of 21 milliequivalents per liter, acidotic. This is called a combined metabolic and respiratory acidosis. Combined metabolic and respiratory alkalosis. This happens when the pH is higher than the normal range. For example, the pH would be greater than 7.45, the PCO2 would be less than 35 torr, and the bicarb would be greater than 28 milliequivalents per liter. Both metabolic and respiratory alkalosis are present. Keep in mind that for a mixed acid-base imbalance, there's probably more than one thing going on. So some clinical conditions that can be additive are a central nervous condition, such as coma, hypo or hyperventilation. This can contribute to respiratory acidosis or alkalosis, combined with a central venous system problem. Congestive heart failure can result from respiratory alkalosis, shock, decreased perfusion, lactic acid production, can contribute to either metastasis or respiratory alkalosis. The respiratory system, with tachypnea, CO2 washout, you would have a respiratory alkalosis. With low respiratory rate or CO2 retention, you would have a respiratory acidosis. The GI system, vomiting, loss of hydrogen ion, would result in metabolic alkalosis. However, diarrhea or loss of bicarb would result in metabolic acidosis. Abdominal pain could be respiratory alkalosis due to increased respiratory rate and pain. So there's a lot of things that can combine together to make a mixed condition. Generally, in the clinical setting, I've seen this, a mixed condition I've seen during CPR for various reasons. That comes to the end of our talk on metabolic and combined acid-base imbalances. Thank you for your time and attention, and I hope you've enjoyed it.